Namaste everyone. This is Dr. Mohit Chaudhary, and today we'll be talking about transfusion associated graft versus host disease. The topic will be covered by Dr. Himani from my department. This is TransConnect April 2024, and let's get on with this very important topic on graft versus host disease associated with the transfusion. Over to Dr. Himani for the same.
Good day to all. I'm Dr. Himani and I will be discussing transfusion associated graft versus host disease under the following headings. First, we will see the introduction and incidence, followed by the Billingham's criteria, pathophysiology, the products implicated and especially the patients at risk, then the presentation, diagnosis, and treatment of this entity, followed by the prognosis and prevention with special emphasis on irradiation. Transfusion-associated graft versus host disease is a delayed immune type of transfusion reaction which occurs 1 to 6 weeks following the transfusion with no other apparent cause. It is a rare, lethal with fatal outcomes in most patients. It is associated with the destruction of recipient's bone marrow, which is the prime cause of its lethality. The cause of occurring is the transfusion of viable T cells, which are present in the blood products and are not cleared off by the transfusion recipient. Since TA-GVHD is a rare diagnosis with less than 1 per million cases and 90% mortality rate, the true incidence is not known. It varies from population to population and the preventive strategies in place. The use of irradiation has reduced the incidence. However, prior to irradiation, the incidence was 1 in 874 unrelated transfusions, 1 in 304 related transfusions, and 1 in 102 mother to child transfusion pair. Billingham's criteria for GVHD states that the graft must contain immunologically competent cells with antigenic differences between the donor and recipients. Also, the recipient must be unable to mount an effective immunological response to eradicate the transplanted immunologically competent cells. In our context, it states that the risk depends upon a combination of factors. For example, the number and viability of the contaminating lymphocytes in the component, the receptiveness of the recipient's immune system to support the engraftment of these viable cells, the degree of HLA disparity between the donor and recipient. Coming to pathophysiology, as we know, human leukocyte antigens derived from MHC is responsible for differentiating self from non-self tissues. However, in TA-GVHD, there is a phenomenon known as the unidirectional tolerance, which occurs in the setting of donor cells being homozygous for a particular HLA and the recipients being heterozygous for it. The heterozygous recipient does not recognize the homozygous donor T cells as a non-self, so there is no rejection of donors. However, the homozygous donor recognizes the heterozygous recipient as non-self and hence attacks the recipient tissues, leading to TA-GVHD. So basically, the donor T cells attack the recipients, but the recipient immune system does not reject the donor T cells. The transfused donor lymphocytes engraft and proliferate to exert their deleterious effects in 3 phases. In phase 1, there is recognition of the host tissues as foreign by the donor T cells and subsequent release of inflammatory cytokines such as IL-1, TNF by the donor T cells. In the second phase, also known as the afferent phase, there is presentation of host antigens to the donor lymphocytes. This leads to donor T cell activation, proliferation, and differentiation into cytolytic cells and also secreting more cytokines. This leads to activation of NK cells, macrophages, and recruitment of further T lymphocytes. The donor effector cells damage the host tissues in the third phase, that is the afferent phase. Now, certain blood products are associated with a higher risk of TA-GVHD. For example, the non-irradiated whole blood, PRBCs, platelet, granulocyte, any cellular components. So, for at-risk individuals, these products should be treated to inactivate the viable T cells. There is no known risk of TA-GVHD with plasma, which is frozen, the fresh frozen plasma, the clotting factor concentrates, the cryoprecipitate, albumin, IVIG, deglycerolized RBC, and any irradiated products. We should know that hematopoietic stem cells should not be irradiated because they will become inviable. For transfusion associated graft versus host disease, certain patients are at higher risk. For example, the ones having immunodeficiency, hereditary or acquired. This includes patients of primary immunodeficiencies such as SCID and Vasco-Dalrich syndrome, those having hematological malignancies like Hodgkin's, non-Hodgkin's, AML, ALL, patients of CLL which are treated with fludarabine. Also, those taking immunosuppressive drugs like fludarabine for any indications, malignant or non-malignant, because fludarabine can cause profound lymphocyte suppression. However, TA-GVHD is not associated with use of glucocorticoids and rituximab. Hematopoietic stem cell transplant patients are also at increased risk of TA-GVHD because they received cytotoxic therapy and numerous transfusions. This may include an HLA matched product, hence they are at a higher risk. Fetuses and neonates are also at a higher risk, especially if they are receiving intrauterine transfusions and exchange transfusions. There are rare case reports of TA-GVHD in preterm infants and neonates. However, there is no increased risk in healthy full-term infants. Interestingly, TA-GVHD has not been described in individuals with HIV or AIDS, but there are several explanations for this. Lymphocytes in the transfused product, they become infected with HIV. Use of irradiated products is a norm in this population. Then these individuals have an intact CD8 response, which is critical for preventing the TA-GVHD. Another group of patients at risk are those which have a partial HLA matching between the transfusion recipient and the blood group donor. A perfectly matched HLA donor and recipient, for example, in case of identical twins, have no HLA disparity and no immune attack will be mounted by the recipient or the donor, and hence no risk of TA-GVHD. However, partial HLA matching, which leads to sharing of some HLA antigens and development of TA-GVHD in recipients with this happens in recipients with all level of immune function, especially so in immunocompetent. The two most important settings in which this matching occurs is the genetically homogeneous populations, example in the island countries like Japan, which used to have a higher rate of TA-GVHD, and those communities in which consanguineous marriages are occurring. Also, the directed donations within the relations have a higher chance of having a partial HLA matching. The symptoms of TA-GVHD develop within 4 to 30 days after a transfusion, with the most frequent symptom being the rash erythema, which is often the first finding, followed by fever. The pancytopenia develops 1 to 2 weeks after the transfusion, but can be seen up to 30 days as well. Bone marrow aplasia, which is the main cause of lethality, also occurs in TA-GVHD. It leads to pancytopenia, which further manifests as fever, sepsis, and bleeding. GI symptom of diarrhea with 7 to 8 liters of diarrhea per day can be there, and this causes significant electrolyte abnormalities. Uh, Hepatitis is also one of the symptoms of TA-GVHD. The most frequent finding of a rash erythema begins as a martyr-papular rash, as seen in figure 1, which often progresses to a generalized erythroderma, as in figure 2, and in extreme cases, it can develop into a toxic epidermal necrolysis. Evaluation of TA-GVHD is done with the lab investigations of CBSC with peripheral blood smear to identify any infection, hemolytic anemia, or hematological malignancies. The KFT, LFT, and coagulation test, especially for those with pancytopenia or elevated transaminases, we can rule out viral hepatitis using viral serology. HLH syndrome has to be excluded by investigations of serum ferritin and serum triglycerides and coagulation studies. Stool testing is done for those with diarrhea to rule out any infectious organism like Clostridium. Bone marrow biopsy and aspiration is done. In case of TA-GVHD, the bone marrow will be hypoplastic or aplastic with lymphohistiocytic infiltrates. The biopsy is warranted if TA-GVHD is suspected, but the diagnosis cannot be made in any other way, such as demonstration of microchimerism. Skin biopsy is more commonly done than liver biopsy because it is easier to perform, less likely to cause bleeding, and skin biopsy is sufficient for diagnosis if a rash is present. In a skin biopsy, usually vacuolization of the basal layer will be seen with histiocytic infiltrate. There can be satellite disc keratosis characterized by single disc keratotic cells accompanied by the lymphocytes. In the liver biopsy, there will be changes in the biliary epithelium, such as the nuclear pleomorphism can be seen, cytoplasmic vacuolization can be seen, lymphocytic infiltrate will be seen, along with biliary statuses and mild inflammation. Chimerism assessment is done by showing the evidence of persistence of donor lymphocytes, which can be differentiated from the host lymphocytes by the following techniques: restriction fragment length polymorphism, the RFLP, short tandem repeat analysis, STR with PCR. Another method is the PCR based HLA testing, which detects the donor derived DNA. Cytogenetics can also be done for detection of Y chromosome in a female patient. But cytogenetics is insensitive and is of no use in male recipients, patients who have undergone a sex mismatch stem cell transplant, and the cases involving transfusion of a blood component collected from a female donor. The CDC confirms the diagnosis of TA-GVHD as a combination of clinical findings and histological findings occurring 2 days to 6 weeks after a transfusion. It also states that demonstration of white blood cell chimerism in the absence of an alternative diagnosis is considered definitive proof. This involves identifying a different HLA phenotype in circulating lymphocytes compared with an HLA phenotype of the host tissue cells. If HLA phenotyping cannot be done, biopsy of the skin or any other affected tissue to confirm the diagnosis. Cases in which the biopsy confirmation is not obtained are referred to as probable TA-GVHD. Hematopoietic stem cell transplantation is the mainstay of the treatment of such patients. It provides a new source of stem cells. The survival rate of patients receiving the transplant is 10%. However, there is insufficient time to identify a proper donor, test them for the suitability to donate, and obtain sufficient stem cells for the transplant. Hence, early recognition is quite important. As soon as the diagnosis is confirmed or strongly suspected, management should be started. Initially, it is given as a supportive and immunosuppressive therapy, such as glucocorticoids, cyclosporines, and it is used to buy time to identify a potential hematopoietic stem cell donor. Some experimental treatments have been tried, for example, methotrexate, nafomostat, UV irradiation, thalidomide, etc. However, not too much success. Recently, a drug called ruxolitinib has been approved by US FDA. It is a JAK1/JAK2 inhibitor. It is used for the treatment of steroid refractory acute GVHD in patients 12 years above, and it has become the preferred option. The prognosis is quite poor. TA-GVHD has a very low survival rate, around 8%. Death usually occurs 19 to 32 days after transfusion. The likelihood of surviving is higher in younger patients and those who have received a leukoreduced or irradiated products, those who have had a longer storage duration of the product which was transfused to them, because these products will have a lower dose of viable T lymphocytes. Also, those who have been treated with transplantation are also likely to survive. Survival has more than doubled after 2000 year from 8% to approximately 19.7% now, because this has been attributed to the improved supportive preventive care and a greater access to hematopoietic stem cell transplants. Although TA-GVHD is hard to treat, it is highly preventable. Prevention is best achieved by irradiation of the blood component transfused, which will destroy all the viable lymphocytes. There are two approaches for irradiation. Selective approach, where the population is having a low baseline risk, we can identify the at-risk individual and give irradiated products. Secondly, we can use a universal irradiation for population with a high baseline risk of TA-GVHD. For example, in this approach, we can irradiate all the blood products. Depending upon its individualized requirement, a hospital can have its own hybrid approach. For example, universal irradiation for all neonates and selective irradiation for other individuals. So let's review the methods to inactivate the viable T cells. Irradiation using gamma or X-rays is done in blood centers before the transfusion. Pathogen inactivation is highly effective, quick, and does not reduce the product's shelf life. Freeze-thaw methods destroys all the viable WBCs. Leukocyte reduction reduces the risk. Irradiation refers to the destruction of the viable T lymphocytes upon exposure of the blood component to radiation waves emitted by some natural or artificial radioactive source. The source being for gamma radiation, it is the isotopes of cesium or cobalt, and also X-rays can be used as a source of irradiation. Irradiation does not expose the recipient or any blood handlers to any radiation, nor does it reduce the efficacy of the transfusion, so they are quite safe. Mechanism involves the DNA and RNA cross-link formation, which inactivates any nucleated cells, including T cells, in the blood components. Prevention of lymphocyte proliferation is also another mechanism. The product must be irradiated within 14 days of collection. The post-irradiation storage time is limited to 14 days. The RBC's shelf life is reduced to 28 days post-irradiation because of the alteration of the plasma membrane, causing a leak in potassium and hence reducing the cell viability. There is no impact on the shelf life of plasma or platelets. 25 gray dose, which produces 5 to 6 log reduction in T cell response to mitogen, more than 90% reduction in mitogen response, and complete inhibition of mixed lymphocyte culture response is considered an effective dose of irradiation. According to the US guidelines, AABB, 25 gray must be directed at the center and 15 gray at any other part of the blood bag. According to the British guidelines, 25 gray minimum to maximum of 50 gray is given to every portion of the blood component bag, never exceeding 50 gray. There are two types of irradiators available, the gamma and the X-ray. The gamma irradiators utilize the radioisotopes which decay over time. Radiation safety protocols and training is required. These take longer time to irradiate the products and there are certain security risks which are associated. However, the X-ray irradiators use non-radioactive source as the source of radiation and hence are easier to use. The gamma irradiators have chambers made of lead to contain the isotopes and prevent any escape of gamma rays from the device. Cesium-137 irradiators contains 1 to 4 pencil-shaped cesium and a rotating platform or cylinder. Cobalt-60 irradiators usually contain rods of cobalt arranged in a circular configuration, do not utilize a rotating platform. These irradiators must be periodically recalibrated to account for the gradual decay of the radioisotopes. Standards and quality check is done using radiation-sensitive labels to differentiate radiated product from the non-irradiated component. Darkening of the film confirms that the radiation requirement have been met. There are assays to assess the effect of irradiation on the T lymphocyte proliferation, such as mixed lymphocyte culture assay and limiting dilution analysis. Monitoring for an X-ray irradiator is done using dosimetry, and for the gamma irradiators using the lengthening of the irradiation time caused by the source decay. This should be monitored periodically for these devices. Verification of the delivered dose must be performed annually for the cesium-137 source and semi-annually for the cobalt-60 source. Also, after any major repair or relocation, verification of the delivered dose must be done for the components. For the personnel safety, TLD batches and rings are used. The facility radiation safety officer determines the individual dosimeter needs. In areas where the radioactive material are handled, all the work surfaces, equipment, and floors that may be contaminated should be checked regularly with a wipe test. In the wipe test, a moistened absorbent material, which is known as the wipe, is passed over the surface and then measured for radiation. Licensing. The hospitals that perform their own radiation must be licensed. The licensing authority is AERB, Atomic Energy Regulatory Board. Qualified radiation safety officer responsible for establishing the personnel protection requirements, proper disposal and handling of the radioactive materials is also employed. Manufacturer of the blood irradiator, the radiation safety requirements during the transportation, installation and validation of the unit is done by them. Suspected malfunction must be reported immediately so that appropriate action can be timely initiated. There are certain disadvantages of irradiation. Apart from being a time-consuming, costly procedure that requires a trained personnel, it also reduces the shelf life of the product due to the alteration of the plasma membrane of RBCs. This affects the inventory and stock of the blood bank. As it increases the potassium load of the RBC transfusion, hyperkalemia can result in the recipient. Irradiating the red cell immediately prior to the transfusion can prevent this increase. To mitigate the amount of potassium, we can wash the blood products, perform plasma depletion, or use potassium adsorption filters. Apart from that, increased pH and plasmahemoglobin is seen in irradiated blood. Also, there is reduced ATP concentrations of the PRBCs. Another method is pathogen inactivation, which is used to reduce the risk of TTI transmission. The techniques are as effective as gamma irradiation in preventing transfusion-associated GVHD. The mechanism involves the damaging of nucleic acids and damaging of the cell membranes. Especially the procedures that damage the nucleic acids can prevent GVHD, such as amortocillin with UVA light used for platelet and plasma, riboflavin with UV light used for platelet and RBCs, amostalin with glutathione is used for RBCs. Freeze-thaw method is another method which inactivates the lymphocytes. However, freezing and thawing of RBCs is expensive, time-consuming, requires the addition of glycerol to prevent lysis of the cells. Thus, it is not an appropriate approach on a large scale. Leukoreduction is another method as per the 2007 SHORT database. Before and after the institution of universal leukoreduction of the blood supply in 1999, there were 13 instances of TA-GVHD, but none have been reported since 2001. This suggests that leukoreduction may reduce the risk of TA-GVHD. However, several case reports have described TA-GVHD in recipients of leukoreduced blood, further emphasizing the lack of complete T cell inactivation and hence cannot eliminate the risk of TA-GVHD. So what we learn is that TA-GVHD is a rare and fatal consequence of transfusion with cellular components. If a patient is at risk of TA-GVHD and is transfused a non-irradiated cellular component blood, they should be monitored for signs of TA-GVHD for at least 30 days. We should always be vigilant in terms of avoidance of unnecessary transfusions and irradiation of blood components given to a high-risk patient who are susceptible to TA-GVHD. We should continuously monitor and be vigilant for them. These are my references. Thank you.